I'm Susan Branscombe. I'm the host of this podcast, Food Addiction, the Problem and the Solution. Today on the podcast, we have Dr. Kim Dennis. Welcome, Dr. Kim.
Hi, thank you so much for having me.
Yeah, I'm really excited about hosting you. We've met. We'll talk about that, and we'll talk about your work, and we'll talk about a number of topics that are key to our topic. Going to introduce you and get into some questions. Dr. Kim Dennis is the co-founder, CEO, and chief medical officer of SunCloud Health, a residential and outpatient treatment center based in Chicago, Illinois. SunCloud Health is a behavioral health and addiction treatment provider that offers comprehensive, integrated care for people struggling with mental health and addictive disorders. SunCloud Health provides treatment for adults and adolescents facing complex behavioral health conditions, including substance use disorders, eating disorders, mood disorders, trauma, PTSD, and behavioral process addictions such as gaming or compulsive behaviors. Dr. Kim Dennis is a clinical assistant professor of psychiatry at the University of Illinois at Chicago College of Medicine. A board-certified psychiatrist, Dr. Dennis specializes in eating disorders, food addiction, addiction psychiatry, trauma, and multi-occurring disorders. She's recognized for her integrated approach to care, incorporating biological, psychological, social, and spiritual dimensions into personalized treatment. Dr. Dennis received her medical degree from the University of Chicago, Pritzker School of Medicine, and completed her psychiatry residency at the University of Chicago Hospital, serving as chief resident. She is published in the areas of food addiction, co-occurring eating disorders and self-injury, and the use of medication with family-based therapy in anorexia nervosa, trauma, and gender differences in psychopathology, and she contributes regularly to national media outlets such as ABC News, CNN, The Huffington Post, and WebMD. A respected leader in clinical practice, research, education, and advocacy, Dr. Dennis serves in numerous national professional, advisory, and editorial roles across the eating disorder and addiction fields. She leads international efforts on food addiction and has been recognized with national clinical awards. Dr. Dennis is a frequent presenter and thought leader advancing evidence-based understanding of eating disorders and food addiction and integrated treatment models. Dr. Kim Dennis also has lived recovery experience with over 2 decades of sobriety, eating disorder, and food addiction recovery. So that's a mouthful. Welcome again, Dr. Kim.
Thank you so
lot.
much. It's
It's
a lot. I'm exhausted.
You've been busy. You're a lot younger than me. You've been busy. Yeah, you and I have met a couple of times. We met first in London at the International Food Addiction Consensus Conference, September 2025, and you were there as a guest speaker, and we'll dive into the work that group is doing and the consensus. But first, wanted to talk about your work. Last fall, I visited you in Chicago and toured your facility, and very impressive with how you do things and what you do. So take a minute and talk about your business and SunCloud and what you do there.
Thank you. It was wonderful meeting you in London. What an amazing conference.
Yeah.
That was so exciting to be there. And thank you for taking the time to come visit us in person in Chicago. I really appreciated that.
Yeah, it was great.
And we really specialize in providing sophisticated and individualized care. And I think that's really important. One, when we're talking about patients with complex issues and complex disorders, because they all have trauma. And a hallmark of trauma-informed care is patient-led collaboration. And including the patient's voice, the patient's choice, the patient's values into their treatment plans. And that doesn't happen all the time at higher levels of care because it's hard to manage. It's more work, but it's so worth it because the benefits are just so great. It's so fulfilling to work with patients and have them have an experience that they're seen, they're heard, and they have a say in, for example, what nutritional philosophy they want to use in their eating disorder recovery, or in their life, or in their food addiction recovery. So I would say that's a hallmark of our program. And we really want to support people in a continuum of care, from residential to day treatment to IOP, to ongoing care for conditions that deserve ongoing care.
Yeah. Um, yeah, you said something interesting, that the patient, and I think this is important. I'm attending the infect school right now, and we're talking about treatment for food addiction and eating disorders and so forth. And one of the things is you have to make sure that the patient is on board. I mean, this treatment is not going to work unless he or she is like saying, yeah, I'm in. What do I need to do? But I would think that you have patients that aren't completely, like their parents have sent them there, or a friend has said, you need to go here, and they're there maybe resisting and in denial. What would you say about them?
Yep, all the time. I mean, one of the things I learned early on in my career as a psychiatrist is, and as a physician in general, you could have the best treatment in the world, and it doesn't matter if it's intolerable to the patient and the patient doesn't want to take it.
Right. Right. They have to be on board.
Yeah. And I think a hallmark of the work that we do is building a sense of safety, building a therapeutic alliance, and building a sense of trust. That doesn't come with coercion.
Yeah. Yeah. You talked about trauma, and what I've learned as a recovered food addict, and in my studying and the work on the podcast and with the Food Addiction Institute, is that almost every case, and I don't want to be broad brush and say every case, but there is trauma, whether it's in childhood or teenage years or later. There is big trauma and small trauma. But talk about trauma and maybe some examples so people can get an idea, which can lead to eating disorders and food addiction.
Yeah, it's pervasive. I would say every case that I see at a higher level of care, every patient that comes here has some way, shape, or form of trauma that has impacted them. Not everybody has a formal diagnosis of post-traumatic stress disorder, but we know that even without meeting full criteria for that disorder, as the DSM lays it out, doesn't mean that the traumas that you've experienced in your life haven't shaped you, haven't impacted you on a biological level, social level, spiritual level. So I think it's critical to understand and appreciate that about any patient seeking care. I think traumas are compounded by the stigma that goes along with any mental health issues. We feel that often as psychiatrists when, we're talking to the larger medical community. I think there's been a lot of progress around decreasing stigma around addiction. It's still pretty pervasive. So trauma is at the root of all of this stuff. And if we fail to recognize that and connect those dots for the people we work with, we're missing a large part of what I think a foundation of sustainable recovery is.
Mm-hmm. And trauma can be, and you give examples too, ones I've seen, but I'd like to hear from you. It can be a divorce, in a child's life, in their childhood. It can be abuse, physical or emotional, verbal abuse. It can be moving to another city and having to adapt. So trauma can look like a lot of different things. People think it's like the big trauma, like sexual abuse. It's not always, right? Talk about that.
Correct. It's really any time the foundation is pulled out from beneath you.
Yes.
Right. So that can be any number of things, ranging from especially in the world today, bullying, racialized trauma, socioeconomic deprivation, food insecurity. not
Yeah.
having access to a whole variety of foods, but only having access to highly addictive, highly palatable foods. And when people experience traumas, whether they're emotional traumas, physical traumas, sexual traumas, it sets up their reward system. It has an impact on their reward system, and reward becomes more necessary and more relieving. It relieves the negative affective states.
Yeah.
So if I come into the world in a pretty good affective state and have, a highly rewarding food or a lot of highly rewarding food, it's going to make a difference in my feeling state, but not as huge of a difference as if I'm coming into the world and I'm already, at a negative sort of set point feeling wise. That food is going to be magical, like, oh, I can breathe, or what a relief. That heaviness is lifted off of me.
Yeah.
And we have access to those from the time we're, 1 year old, 2 years old, 3 years old.
Right. Tremendous access. So that, if the trauma and the food serves a purpose to make us feel better, or even numb out and not feel at all, to deal with the trauma. And that's where eating disorders and food addiction can really start early on in our lives. I love your approach, which is the integrated approach. Each person's path in addiction and recovery is very unique. You might have one person that is alcoholic, maybe bulimic, maybe a smoker. Another might be morbidly obese and have alcohol addiction, bulimic tendencies, vomiting, laxatives. Another might be severely underweight and doesn't see it and is not eating what her body needs. What would you say about the people and how different they come in and how you assess them?
Yeah. So again, coming from a trauma lens first and always, really, but then really trying to understand what a person is coping with, how a person is coping, as how was this adaptive for that person at earlier times in their life when they didn't have access to good medical care or good addiction treatment or good eating disorder care or good mental health support. And then helping those folks identify, how those behaviors became ingrained on a biological level. This isn't just psychological. There's biology that drives this. I think oftentimes we look at behavioral health and assume, well, if I want to drink a gulp of water right now, like I do that, I decide that it's willful, right? And we apply that same thing to addiction or behavioral disorders, where it's not as much of a choice as it might look like.
Yeah.
And forget that there's biology driving compulsive behavior and that a person can't simply choose to not do it.
Right. Yeah, we're going to talk about some of that a little bit later, and that's really key. I'd like to also talk about behaviors and how they can be addictive themselves. So we'll get into that. But as we kind of wrap up the focus on SunCloud, I mean, people have to change their attitudes toward life and want something different, and find ways to deal with their lives, which doesn't involve food. How do you do that? When patients come to you, what do you see the keys as being the most successful outcomes? What are the keys to the most successful outcomes as you see people wanting to change their lives?
Yeah. So to some extent, meeting people right where they are, meet people where they're at, just don't leave them there. It's one of the sayings we use.
Love that.
So meeting people where they're at and journeying with them. I think trauma treatment, trauma-focused, trauma-specific treatment is a big part of that. And I think helping people to understand that everybody has their own unique fingerprint in recovery. They're going to have their own. And it's my job as a clinician, it's our job as a clinical team at SunCloud to help people shine a light on what their path might be, and we don't always know. I think that's another key part of, not walking around thinking I'm God, right?
Yeah.
I know the solution for everybody. And we hear a lot of that in the eating disorder world, in the food addiction world, among addiction treatment professionals. So having a little bit of clinical humility, and understanding we know only a little.
Yeah.
If I'm awake to it, more will be revealed. That's part of why I think research is important and testing things out. You could do that with individual patients. Let's test this treatment out and see how you respond to it.
Right.
Maybe it'll work, it might not. Here are the risks, here are the benefits. Do you want to give it a try?
Yeah. That's really important what you just said, which is that we don't presume to know what people need to recover. We think we have an idea based on research and what we see in you, how you've answered questions and so forth. But that humility piece is so important, and it's lacking in the typical Western medicine treatment, isn't it?
Yeah. And I would say particularly in the eating disorder field, the addiction field, one of the things that's critical for me as a person in recovery is to be able to see beyond what worked for me.
Yes. Yeah. Oh, that's good. Yeah.
Gotta be able to see beyond my own. Yes.
When you have an ego and I know what's wrong with you.
Yeah. So, practicing seeing beyond my own eyelashes is a daily thing I bring into practice.
Yeah. Well, let's move on to eating disorders and food addiction. You and I have talked a bit about this. I know you have some opinions about it. You work in the eating disorder field, but you know that there are biological responses to food as we talk about food addiction as a substance use disorder, ultra processed foods. So let me set this up for you. You had mentioned the DSM. Currently in the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders with the American Psychiatric Association, eating disorders are recognized distinctly as psychological disorders: anorexia nervosa, bulimia nervosa, and binge eating disorder. Food addiction, as we've talked about in the conference, was, has addressed, and the movement there has addressed. There is a tremendous amount of evidence that this is a brain response. This is a brain disease, that when we ingest certain ultra-processed foods, sugar, other things, some people have peanuts, some people have cheese, there is a response biologically where there is a trigger where we want more. When we don't have more, we start craving it. When we stop eating it, we start having withdrawal. All the symptoms of an addiction, a physical addiction, similar to alcohol and drugs. So talk about the pros, the differences in eating disorders and food addiction, and what are the misunderstandings? It's a big question, so take your time.
Yes. So a couple of things that I think are important. One is that eating disorders are distinct from food addiction. Eating disorders are biological, psychological, heavy psychological, heavy social impact on the development of eating disorders. We focus a lot in the eating disorder field on combating distorted thoughts about dieting, distorted thoughts about body shape and weight, body image obsessions and concerns. And the sort of hallmark of treatment for eating disorder treatment is cognitive behavioral therapy, enhanced CBTE, which was really based on a trans diagnostic theory of eating disorders put out by Chris Fairburn in the early 2000s, which said essentially, it doesn't matter what the eating disorder diagnosis is, dietary restraint is a core feature of all of them. I think that's a theory that's been debunked. There's more evidence against the validity of that theory. And unfortunately, over the last 2 decades, we've seen little to no progress in treatment response rates for people with binge eating disorder. And I think people with binge eating disorder who go to treatment programs that only focus on dietary restraint are, many people respond to that, but there's a huge percentage of people who don't. So we're missing something. 30 to 50% of people with eating disorders are not responding to our current gold standard treatments. That's a huge amount of people. And eating disorders, while they are distinct from food addiction is a substance use disorder. We believe that the certain food substances themselves are psychoactive and are causative, propel and advance the illness. In the eating disorder world, the sort of widespread dogma is all foods fit, all foods are equal, no bad foods. And while food is amoral, I don't think heroin has a morality to it either. I don't think cocaine has a morality to it. It depends what you do with it and how it's impacting you.
Right.
So while ultra processed foods are neither good nor bad, there's data that we know based on population studies that, for example, Black and brown people in the US, lower socioeconomic status people in the US who have no access to whole foods and are predominantly eating ultra-processed foods are dying at rates of, 4 or 5 times from diabetes-related complications, from cardiovascular disease complications. We could make an argument that that's a moral issue, right? And why can't more people have access to foods that aren't linked to cancer?
Let me ask you as you go there, and I'm going to come back to some other stuff you said, but even if someone is in a lower socioeconomic neighborhood, and we call them often food deserts, where you can't get fresh vegetables and whatnot, they're eating some bad foods. But if they ate a more moderate amount of those foods, let's say 25% of what they're eating, perhaps they would not be overweight and unhealthy.
Yeah, I mean, we don't even have to talk about weight, right? Which is
that's
very controversial in the eating disorder.
We'll talk about
right. We can talk about high blood pressure and diabetes. So if somebody's only able to have, 90% of their diet, 90% of their meal plan consists of ultra processed foods, and only 10% is whole foods, and you can help that person have 60% of their diet in ultra processed foods and 40% in whole foods, you're going to improve their health outcomes.
Despite weight. So I didn't mean to go there, because we know that not all food addicts are obese. Not all people who are obese are food addicts. Okay, so we can go there. But if somebody is eating, let's say it's a person who's eating Kraft mac and cheese and Twinkies, and that's all they eat. If they eat tremendous quantities of it, they'll probably gain weight. But if they're eating little quantities of it, they can still be unhealthy. They can still have all of these sort of metabolic disorders that cause them to be unhealthy, right?
True.
Yeah. So we're kind of going off on a tangent, but I think it's important to talk about this so that people understand it. But the eating disorder world. Go ahead.
Food is a psychoactive substance. And if you don't believe that, think about your favorite food item from the holidays.
Yeah.
And how you feel when you think about that food item, when you think about consuming that food item. And compare that feeling to how you feel about having a green bean,
Or a celery stick. Yeah.
That's not psychological. That's
Right.
that's a biologically driven difference in feeling
Right.
state.
Right. But when we talk
So,
about food addiction and addiction in general, some people can have a glass of wine
yeah,
and not
for
want
sure.
another glass of wine or leave a half a glass of wine at the restaurant. But some
Yeah,
people, addicts tend to keep thinking about the glass of wine, keep thinking about that sugary Christmas item, and they
yeah.
can't stop thinking about it. Then they think, okay, I'll just have one, and then they can't stop, and so forth. That's the addiction we're talking about, right?
Yes. Yep, exactly. And I think what you described is really at the root of why it's so hard for people who don't have addiction to understand that it's more than just psychological,
Yeah.
right? Well, I can stop after a glass of wine. I know if she really wanted to, she could too. Or maybe if I teach her a few more skills, she could too.
Mhm.
Right? And the same is applied to how people eat, particularly when loss of control eating is part of their picture.
Yeah.
Whether they
Yeah.
have a food addiction or an eating disorder, or, and this is my personal favorite, both.
Yeah.
People can have both co-occurring, just like
Yeah.
people can have high blood pressure and diabetes, or just high blood pressure.
Yeah.
When somebody has both, as a doctor, I want to be able to treat both and not say, that other one doesn't exist. This is just an eating disorder.
Yeah. See, that's why I think there's so much confusion about this, because they're not siloed. There's
Yeah,
overlap. There's overlap between eating disorders and food addiction. And there are some addictive behaviors, like gambling, porn addiction, that kind of thing. Those are behaviors. They can also manifest themselves with food. I only eat when I
right.
read. I only eat excessively when I'm alone.
Yeah,
Right?
it's very complex.
Yeah.
It becomes very, very, very complex.
Yeah.
So I don't think there are simple answers.
Yeah.
Yeah.
One more as we before we move on to the next topic, I'd like to hit I guess two things, and they're going to be two questions, but I'll try to put them together as we are sensitive to the time. But binge eating disorder, um, and this may just be a tough question to answer, but I think of binge eating disorder as being kind of the evil sister of food addiction. Aren't there people who are diagnosed with binge eating disorder who are actually have the biological addiction to food?
For sure.
Yeah.
And I would say conversely, there are probably people who are diagnosed with food addiction who may not have food addiction, but they have binge eating disorder.
Yeah. Yeah.
No?
And don't have the addictive, the addictive response. The other question I had was, and you and I had talked about this when I visited you in Chicago, that the eating disorder community doesn't exactly embrace the idea of food addiction, right?
That's putting it very mildly.
Okay. That's where I want you to take it from here.
I would say it would be more accurate to say the eating disorder community demonizes the concept of food addiction.
Yeah, that's a shame.
Changing. That's shifting over the last, I would say, 3 to 5 years. When I first started in the field 20 years ago, I had no idea that it was such a, demonic thing to be talking about. And the first time I gave a talk about, integrating 12-step recovery into eating disorder treatment, I saw for the first time just how charged people got and how negative people are against it. And nobody ever accepted any talks about food addiction back then. And over the last, I'd say 5 years or so, if I submit to talk at a conference and it's on food addiction or anything about addictive eating, people are much more open to and wanting to learn about it, which is exciting.
Yeah, it is exciting because as long as we're not accepting each other and what's going on here, the harder it is going to be to make progress in treatment, don't you think?
Yeah, the people who suffer are those 30 to 50% of people who aren't getting better and who are
Right.
thinking it's because they suck, or
Right.
they're thinking
That's
it's
me.
because they're broken
Right.
or there's no hope for them.
Yeah.
And so we owe it to those people to expand our treatment options, to expand our theoretical orientations, to
Hmm.
keep learning.
Yeah. Yeah. Well, I'd like to move on to the topic of harm reduction versus abstinence. And we've talked about this in the Food Addiction Institute at ad nauseum, and we haven't come to quite a conclusion yet. We'd like to have you on the board, but I think we're going to get there, and it's going to be a collective response to here's what we ought to say as far as what we believe.
Yeah.
What I'll just say what I believe is that a food addict, a true food addict, must have an abstinent food plan. And that abstinent food plan can look different for me than it does others. Somebody else's food plan might be, that they can't have nuts or cheese, or I can't have pizza or chips. Some people can have those. So the abstinent food plan can look different from person to person, but it still has to be an abstinent food plan for a food addict. And for me, that means weighing and measuring my food. Not everybody has to weigh and measure her food. I was a volume addict. So, what does that look like in compared to harm reduction? Some people say, well, just try to eat a little bit of that. What would you say about this?
So I would ask you a question,
Yeah.
because that's what I do. So if somebody had a heroin addiction, would you say they have to have an abstinence treatment to recover?
I believe so.
If that person, does that mean that that person can use cannabis?
I hear where you're going here. Well, I know that as a recovered alcoholic, I cannot have anything that alters my mood. So we start there. I can't have cannabis. I can't have gummies. Because it would alter my mood and then give me a place to go to change how I feel, so that I feel better. And that's not the basis of recovery.
What if you were an alcoholic that also had major depressive disorder? Would you be able to take an antidepressant?
Yes. And I
But
do.
that alters your mood.
Well, that's a good point.
I think that's the important point,
I hear
right?
you.
Because if you're
Yeah.
taking an antidepressant, what needs to be involved? You need to have a relationship with hopefully a competent authority figure.
Yes.
You surrender your treatment to that person as the authority figure, and you take it as prescribed. Right?
Yes, I understand. Yeah.
Which is different than I'm going to go use heroin or alcohol or cocaine and take it when I want, how much I want, from a dealer on the street who has no credentials or no.
Right. Yeah, despite the
Right?
source, I think what you're saying is, Susan, you're not completely abstinent. Well, I don't want to put words in your mouth, but I hear what you're saying, that I am taking a mood-altering substance.
I think abstinence is a tricky word.
Yeah.
Because it means so many different things.
Yeah.
I think all treatment is harm reduction. I don't think anyone from their very first AA meeting stopped drinking, stopped smoking, stopped compulsively overeating food, stopped shopping, stopped all the stuff. It's gradual over the course of recovery
journey.
Right?
Yeah.
And that's similar to what we do in treatment. We always want to So if somebody, for example, is using, it has a heroin use disorder, and would you consider somebody being on Suboxone,
You'd have
an
to tell me what
abstinence?
that is. Yeah,
So that's a opiate replacement
I
medication.
see. It's almost like methadone.
Yeah, it's similar to methadone, but I can prescribe it out of, my
I
office, and
see.
the patient can get it from a pharmacy.
Okay, so it's like helping the person get off heroin, right?
Yes,
But
and
it's still a drug.
potentially not die of a drug overdose, in the next 5 years or in the next 10 years. It
Hmm.
decreases the risk of that person dying prematurely,
Yeah,
right?
yeah,
And if that person happens to be my father, and being on Suboxone can keep him alive
yeah,
for some of my life milestones, like graduating from high school or getting married, right? That's going to change my trauma history,
yeah.
right?
Let's talk. Let's take it back to food though. Harm
Okay.
reduction versus abstinence. We're talking
Yep.
about drugs, and we know that food addiction is a substance use disorder. We're trying to get it recognized, like alcohol and drugs, as a substance use disorder. Let's talk about harm reduction. I know that I cannot eat a Reese cup. I can eat one today, maybe, and I'll say I'll eat one tomorrow, but pretty soon I'm going to get back to
Yes.
eating a bag of Reese cups. I know
Or
that.
two.
Or two,
Yeah.
and then I'll do it secretly so nobody knows. But we
Yeah.
wear this disease, right? So for me,
Yeah.
it was the obesity.
Well,
But
sometimes
what
we do. I was bulimic, so I didn't wear it.
you didn't because I, I binge didn't purge is what I did. So
Yeah.
that's why I
Yeah.
was obese. But what would you say about the person who knows that he has a trigger food like a Reese cup, like M&Ms, and they can't eat just one. They can't just eat a handful.
Yep. So
Uh,
some people know that about themselves. Um, some people don't know it about themselves, and that's where, okay, let's do the experiment as part of treatment, and exposures as part of treatment becomes important. There are people who can have risky foods that they identify as like, well, this food is like, sometimes leads to binge, sometimes doesn't in
right?
certain situations. Like I
Yep.
can have it out with, at, an event at somebody else's house. I talked to my sponsor about it before and after, and I
Yep.
do fine. And I've shown that over the course of like a year, 2 years, 3 years. But I can't have it in my house, So I think there's so many shades of gray
Yeah.
in our relationships with food, that it's all about harm reduction in my opinion. And also there are people who aren't interested in abstinence, so as a doctor, if one of those people are my patients, I still want to treat that person,
Yeah. It gets back to
and
clinical humility, like you say. So, yeah, I hear what you're saying. Abstinence is almost like so black and white that you want to hold out the possibility that can you get better? Or can you have a change in your life
can you have
by
meaningful change,
yeah,
you know
without having to be so strict about abstinence. For me, I know it's not the case, but I
yeah.
know there are many others that it could be. And so
Yeah.
stay tuned.
And I'm sure, over your years in recovery, you've seen people who, maybe have a different experience of recovery, of sort of waxing and waning,
Yes.
and that's,
Relapsing, slipping, and
yeah.
learning. We call
Yeah.
it experimentation often in recovery, but can you eat in a controlled way certain substances? Can you
Right.
stop from starting? Can you stop once you start? And those are, the basis of my
Yeah. And
experience.
as an eating disorder professional, I wouldn't even say in a controlled way, because so much of eating disorder pathology is about over control, attempts to
Yes.
over control your
Yes.
food. I
Yeah.
would say, can you eat in a way that gives you freedom?
Freedom. That's well put.
You
Yeah.
know,
Yeah. I hear what you're
um,
talking
which I
about
think
here.
I think is the whole goal of recovery, is to give people
Mm-hmm.
greater and greater amounts of freedom
Freedom. Yeah.
to be who they are, to have
Yep.
meaningful relationships, meaningful work.
Yeah. Yeah. Getting goosebumps. Yeah. Well, it takes me, we're going to talk about GLP-1s and your opinion on that and what you're seeing there, but I'd like to have the listeners hear about your personal history. You and I share some things in common, and I believe it's one of the reasons that you're so passionate about it and have been so transparent is that I'm
Yeah.
a recovered alcoholic. I'm a recovered food addict. I think your approach to it might have involved bulimia. For me, I just, I used to weigh 203 pounds and was very, obese and had a lot of health related things. So I used food to get sober and it worked. And then I had to get to the food because I couldn't be free until until I did both. So talk about your personal history.
Yeah. So I think it's important to start with, I grew up with, violence in the home. There was sexual abuse in my history, in my mom's history, in my sister's history.
Oh.
There was food insecurity in my history. So all of that, was sort of laid this foundation that impacted my concepts about who I am, my concepts of what a higher power is, my concepts about other people and their availability or not to help me versus hurt me. And I brought all of that to my help-seeking behaviors, which were delayed for many, many years. But I've been sober for 22 years now, and
Congratulations.
abstinent from binging and purging, which encompasses food addiction recovery. And I mean, technically I wouldn't have met full DSM criteria for bulimia because I didn't have like body image disturbance. Like I knew that I needed to and I wanted to actually gain weight because I was binging and purging so much every single day that I was actually losing weight. And I didn't want to look sick. I was in
Yeah.
medical school. The last thing I wanted was anybody to identify me as like being sick or having anything wrong.
Yeah.
And I ran with a group of other med students, who drank a lot. We're just the partiers, so, but I was blessed to finally land on somebody who was sober 30 years, was a trauma therapist, understood addiction and said, I think you have, I think you should try out some of these 12-step programs and see a nutritionist. He knew how to like guide me to a nutritionist, which is very, very rare, certainly back then, who understood that when I ate a bunch of added sugar, I couldn't stop. Like I was not binge eating broccoli, I'll put it that way. And I was eating massive quantities of food, with spending my student loan money on it, and putting myself into huge but that's extremely rare. Most people who were struggling with what I had would have ended up in standard eating disorder treatment. There was very limited treatment back then for eating disorders even, but it was all still, in order to recover, you have to like expose yourself to having a cupcake and eat like a lady.
Yeah.
Which that approach, I do believe that I would be dead today if that was the only treatment approach I was ever exposed to.
Yeah.
So that's part of why I'm so passionate about this.
Yeah, no, I see it in everything that you do. Talk about how you dealt with your childhood, which sounds, pretty rough with the violence. So how did the abuse back then, the trauma, how did you work through that? Was it therapy?
A lot of years of
A lot
therapy
of therapy. Yeah, me too.
and a lot of corrective experiences with sponsors, with other women, men
Yeah.
who were in recovery themselves and living along
Yeah.
spiritual lines,
Yes.
and putting something bringing me to those rooms, and something bringing me to that therapist and helping me stay with that therapist,
Yeah. Yeah.
which is not what I would have done left to my own devices. But even that, like I haven't had alcohol in many, many, many years. I haven't had sugary food items in, many, 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 many years. But there's no ceiling on spiritual growth,
Yes.
so
Yeah.
I'm still recovering and I'm still growing and I'm still learning. And I hope to continue doing that for as long as, God graces me with the capacity to be on this earth.
Yeah. Well, I hadn't planned on going there, but I know that on podcasting we must be flexible. So I'd like you to talk more about that. I think a lot of people. My dad was an alcoholic, and when it was suggested that he should try AA, he said, "No, no, it's religion, it's God. I don't want any part of it." And
Yeah.
so he never really got sober in that way. And so that blocks people, the spiritual, and they have this sort of, I think, idea about what it looks like, that I've got to believe in God and Jesus or whatever. And it's not that way. It's like, could I stop eating on my own? No. Well, then how did I do it? Well, it was something beyond me, and I don't know what that is. If it's the fellowship, if it's somebody watch, I feel like there is a spirit watching over me, and I pray and I tap into God. That's lost in some of the clinical stuff we see today, but you believe it, and I'd like to hear
Yeah.
from you on it.
I believe it, and I believe it's critical to include it in
Yeah.
treatment and in recovery,
Yeah.
And I think especially to like people like hearing someone they feel like they can follow and get behind, is it in the black or is it in the white?
Yeah.
And I don't want any gray, I don't want any doubt. What people don't like to hear is what you just said. There's a great deal of mystery in recovery. And something brought you where you were. Something has brought me where I am. And
Yeah.
I don't know exactly what that is. Nobody wants to hear, I don't know.
Nobody. Yeah. Your own
And I think that's
concept of higher power, right?
yeah, I think that's a big barrier for a lot of people. My dad was an alcoholic as well. I was raised Catholic, so we went to church every Sunday, but none of that translated into like how our house was run, how we were living.
Yeah.
So I try to help people understand the concept of a practical spirituality, and that it's inside of them.
Yeah.
It's deep down inside of them. I don't know exactly what it is, but I know it's better than starving yourself. I know it's better than not, eating yourself to death. I know it's better than drinking yourself to death.
Yeah, I've got a couple of other subjects to hit. One is GLP-1s, if we could spend a few minutes talking about that. That seems to be the way people are losing weight today. A lot of celebrities, a lot of my friends are taking it. And, I think if you and I, gave out, how do you lose weight? I'd start talking about, abstinent food plan and recovery programs, but not everybody wants to do that. They want an easier way. So talk about Wegovy, Ozempic, and GLP-1s today, and do you prescribe them?
Yeah, so I always start that conversation with why do you think you need to lose weight, or why do you want to lose weight? And let's talk about that first. And sometimes that's a conversation that goes on for weeks, months with some people, years for some people.
Yeah.
But like all medications, depending on like who's taking it and for what and in what dose and in what way and with what other with what other psychological supports, it can be helpful or it can be harmful. So I think these are medications that for some people help specifically with food addiction. There are studies emerging that show benefits with alcohol use disorder. Probably the most studies. I think there's only one study that has looked specifically at food addiction. They're being looked at for binge eating disorder, bulimia, but again, very, very few studies. So we don't really know yet. If somebody has type 2 diabetes, what used to be called non-alcoholic fatty liver disease, obstructive sleep apnea, cardiovascular disease, we know from pretty robust evidence that these medications are really good for those and save lives.
Yeah.
You know, so if I'm working with a patient who has one of those, that's a medication that's something that we talk about, and we monitor. You know, if they also have an eating disorder, are they healthy enough to even start that medication? Are they eating enough to be able to start that medication?
Mm-hmm.
And then once they do, you know, what's going on with their addictive thoughts? What's going on with their food intake? Are they able to maintain muscle mass? Are they able to, you know, eat enough calories every day to support their body's functions and not cause harm? So it depends on the person, and always with a lot of close monitoring and measuring of how, you know, is this treatment helping? Is this treatment harming? And if so, in what ways? And always not as a standalone treatment,
right.
You know, because
not just by
all
itself.
the other work still needs to be done.
Yeah.
And when these medications do work, I think it helps the person to be able to do that other work. You know, helps that person to be able to actually engage in trauma-specific therapies.
Right, because you have to if you stop taking it and you start eating again, you know, and there's an obesity problem, and let's just start there, that they're taking it because they want to lose weight. You've got to get to the, as we call them, causes and conditions of why you're using food. Why are you eating more than your body needs, right? So you've got to find a way to figure that out. I mean, if you stop taking the medication, your appetite's going to come back and you're going to start wanting these things, maybe drinking more, right?
Yeah, for sure.
Yeah. Well, I know there's a lot there with GLP-1s, but we've seen some incredible things going on. We know that there are some side effects we hear about, nausea, vomiting, and whatnot. But let's move to our last topic, and then I have a signature question I want to ask you about. Hopefully, you've got the time here. You and I, well, let's talk about the world. The world seems to be embracing the ultra processed foods, as we're not hearing about food addiction as much, but there's a lot of pressure. State of California changing school lunches. Europe is taking some things out of their foods. And we're seeing that there's a lot in these foods that people don't realize. And there's a spotlight being shined on it, on these things. So the world is changing, and some pressure to, you know, high fructose corn syrup, Coca-Cola, Kraft. I mean, they know we like our ultra processed food. So as I mentioned, you and I
means a lot of money for them.
Oh my gosh, it's in the lobbying and everything. It's just like big food, you know, big pharma, you know, they're powerful groups. So it's like, here's this little food addiction group, you know. So I think we're going to get there. But let's go here. As I mentioned, you and I met in London at the second annual conference. You spoke there, International Food Addiction Consensus Conference. So I'll set this up for the listeners. A few years ago, an international group of about 40 clinicians and researchers reached a scientific consensus that ultra-processed food addiction meets the criteria of a substance use disorder, similar to alcohol and drugs, showing loss of control, withdrawal, continued use despite harm, are just a few hallmarks of addictive substances and behaviors. That work has fueled a movement and advocacy to include food addiction, specifically ultra-processed food addiction, as a recognized diagnosis in the World Health Organization ICD, International Classification of Diseases, which would unlock standards for treatment, research, and insurance reimbursements. So you are one of the 40 that signed the consensus statement. I looked and saw your name on there.
Yeah.
So talk about this movement as we wrap up. I've got one more question. Why you're part of it, why you believe it, and what do you think will happen?
Yeah, I'm part of it because I think this is a huge missing piece to a lot of the health problems that our country and the world really faces today. So not only just addiction, but also, the huge healthcare costs that globally different countries are facing. And I think it directly impacts mental health, eating disorders, and food addiction in particular is, I feel like it's very similar to what we saw with big tobacco,
Yeah.
40 years ago, 30 years ago, 50 years ago now, I'm not
Yeah.
sure. And I think this is, one of the last sort of bastions of, talking people out of the reality and talking people out of their lived experiences. Like, no, that's not addictive. Don't be so silly. You just need to eat less or exercise more. That doesn't work. It hasn't worked for so many people. Like, what we've tried has not been working. And I think a large part of it is because we've missed a lot of the addictive nature of foods. I think big corporations know this. I mean, they pay food scientists to design foods that make people want to eat them more and shut off their, take away their brakes and hit the accelerator. Right. And they're making billions of dollars. And then generating billions of dollars for the healthcare system as well. And it's not good for individuals' health. It's not good for public health, and it's unsustainable. So I think I really feel like the sort of forces are sort of coming together, and the data speaks for itself.
Yeah.
So I'm hopeful that this becomes a legitimized diagnosis so that we can have money to study treatments.
Yes.
What's the best treatment? We don't really know because it's not really technically a thing.
Yes.
Hasn't been legitimized in our diagnostic manuals, and it really needs to be.
Do you think they will require research before they put it in there, or do you think they'll put it in there and say, "Hey, we need more research, but we'll go for what you're saying"?
Well, there's actually in the DSM, there's there is a way to have it in there as a research criterion, right?
Okay.
So this is a diagnosis that we think is a thing. Like, this happened for binge eating disorder. Before it officially became a diagnosis. And my hope is that Nicole Lamina and Ashley Gerhardt, who are working in the US on the DSM front, and their whole group can get it into the research criteria at the very least. My hope, too, is the ICD really takes to heart the rebuttal that a whole group of us wrote and participated in, and acknowledges it in the ICD.
Yeah, I've reached out to a lot of fellows and friends and people to write to the ICD. They've invited comments, and I think they've got hundreds and hundreds of comments from people. So hopefully that's
awesome.
Compelling. Yeah, hopefully it's compelling enough for them to do it. We're waiting to hear, right? Yeah. Well, as we close out, this has been great. It's great to talk to you. I love hearing you talk. You explain things in a way that I understand,
Awesome.
and I just love your work. I love your passion, and I'm a believer in you. So thanks for taking the time.
Thank you.
We'll close out here. In another podcast, I heard you share some words of wisdom, which I wrote down. Honor yourself. Honor your truth. Every patient has the solution inside herself. Know that you are enough. So what would you say to someone out there who's overweight, has tried many diets, lost weight, gaining it back, can't stop eating, or they are using food to control, maybe through anorexia or bulimia, and they're hiding it. There are many ways that food manifests itself into hurting ourselves, and they feel hopeless and desperate. What is the hope for her? What would you say to her or him?
Don't stop fighting, don't stop seeking.
Mm.
And if you're seeking help and you're met with something that doesn't resonate with you, keep seeking. Keep seeking, because there are new solutions being developed every day. And there are many, many, many different types of help that help different people.
Yeah.
And it's not about the weight.
It's not
Everybody
about the
comes
weight.
in wanting it to be about the weight, but it's not about the weight.
Right.
And I do believe that when we straighten out spiritually, the physical, the emotional, the psychological, the social all falls into place.
Mm-hmm.
And the spiritual straightening out starts with finding a helping relationship that feels safe, that leaves you feeling like you're seen, that
Mm-hmm.
leaves you feeling like you're heard. And when you find that, stick with it.
Yeah. Hang on to it. Yeah.
Yeah. One of my favorite acronyms for binge is because I'm not good enough.
Yeah. Yeah. And we are.
So,
hey, thanks for joining me today. Thanks for taking the extra time.
you're very welcome.
Yeah. It'll be a great episode, and I'll let you know when it comes out. We'll get it out